Well, good afternoon, everybody. Welcome, and thank you for joining our e-webinar today. Our subject today is transcranial Doppler and collateral flow patterns, and our presenter is Donna Lee Davis. My name is Katie Vollrath, and I'm the TCD clinical specialist with Natus Neurology. I'm proud to be hosting today's session in conjunction with our education team. In a moment, I'm going to introduce you to our speaker and presenter, but first I want to go over a few housekeeping items. Today's session is being broadcast across the internet, which means the presentation can be heard through your internet speakers. So I'd like to introduce our speaker. I've known Donna Lee Davis for many years now, and I have the greatest respect for her. She's a clinical nurse specialist as well as a TCD technologist with vast clinical TCD knowledge and experience. Donna Lee began her career in vascular ultrasound in 1986. She then worked for 12 years as director of the Cerebral Vascular Laboratory at the Cleveland Clinic. I had the privilege of working with Donna Lee for a number of years after that when she was a TCD clinical specialist with Nicolay Biomedical. Currently, she is the director of her own company, TCD Education. Donna Lee has earned her stellar reputation as a TCD expert, having presented multiple talks on TCD at conferences and seminars and many specialty courses. She is well published and has also very many poster presentations, both domestically and internationally. She has been presenting periodically in our TCD educational webinars for Natus since 2014, and has always met with audience enthusiasm and wonderful survey results. We're proud to welcome Donna Lee Davis today as she educates us on TCD collateral flow patterns. Welcome, Donna Lee. I'm going to hand the presentation over to you now.
Thank you, Katie. I appreciate the wonderful introduction. Okay, today we are going to talk about collateral flow patterns. As Katie said earlier, I have my own company now. It's called Transcranial Doppler Education, or TCD EDU, and I perform on-site training throughout the country. And it is a great honor to be involved with Natus doing this webinar. I will be doing another webinar actually in August for the SVU. We're going to be talking about transcranial Doppler and just basic transcranial Doppler imaging. So with that, let's begin. Transcranial Doppler and collateral flow patterns, this is the topic of today's webinar. We're going to talk first a little bit about just the basic neuroanatomy, because you definitely have to understand the neuroanatomy and a little bit of physiology to comprehend the collateral flows. So vascular anatomy, we're going to talk about that. That's my little flipper of the dolphin there. The two vessels we really care about in the brain is the common carotid artery. In the common carotid artery comes off of the arch on the left side of the body. And on the right side of the body, it comes off of the brachiocephalic rhinomenon. And it gives rise to the internal carotid artery gives rise to the anterior circulation, and the external carotid artery we're going to talk about as well. It supplies a collateral flow pattern. So the common carotid artery is the big vessel that we care about in the anterior circulation. Okay, anatomy. Right here, you see where the arrow is there. That is your foramen lacerum. Your foramen lacerum is this hole right here. It is where the internal comes up and breaks through the bone. Our brain is held up with the skull base, and this is the hole. It's right on the other side of our nose, where the internal comes up, loops behind the eyes, and then forms our intracranial vessels. Now, a lot of times the doctors will ask you to find a petrous portion internal carotid artery. we cannot identify, and this is important because I get calls all the time from people saying, you know, Donnelly, my doctor wants me to find the petrous portion ICA, and I'm not able to do that. Can you tell me how I can? The petrous portion is actually the internal that's embedded coming up through this canal. We cannot directly identify that, and this is all going to make sense when we go to this next slide. You see right here where the error is, I'm going to point right here. Oh, I'm sorry, I want to go back. Right here is, see this bone right here where my arrow is? That is that's your foramen lacerum. That's the bony ridge or canal that the internal goes through, and it now becomes behind the eye. When we're doing the orbit of the eyeball, we're literally looking at this area of the internal. This is the carotid siphon, okay? We cannot look at the petrous portion of the ICA because the angle is too sharp inferior. So we cannot directly. We can indirectly look at this vessel with the pulsatility index. If the pulsatility index is low, we know there's a problem down in this area here. But we can't directly look at this segment. So always remember that. If the doc says, can you find the petrous portion, just say, well, I can't, but I can give you the internal carotid artery siphon behind the eyeball. So you can look at the siphon, but you can't look at the petrous ICA. I get calls all the time about that. Okay, so quickly let's talk about the anterior circulation, then we're going to move on to the posterior circulation. The internal carotid artery, and I know this is pretty basic, but the internal carotid artery comes up, loops behind the eyeball here, and stops being an internal. It ends being an internal right here. The first branch of the internal carotid artery behind the eye is the ophthalmic artery. The ophthalmic artery, as you know, supplies blood to the eyeball. The ophthalmic artery we're going to talk about a little bit later on in the procedure, or in the end of the program. The ophthalmic artery will interconnect with the external carotid artery when your bridges, the ACOM and PCOM, are not open. So we will have face-to-eye collateral, if you kind of think about it like that. And again, we're going to talk about that later on. But right now I want you to look at the internal comes up, loops behind the eyeball here. You see this little tiny distal right there? That little string, that is your posterior communicating artery, or your PCOM. I want you to look at how small that is. That thing is smaller than a piece of spaghetti, if you think about that. Very, very tiny. The communicating arteries, whether you're doing imaging or non-imaging, you cannot see them routinely. You cannot. They are very passive. They even kind of sag down. If you look at some angiograms, in fact, I have some we'll show you. If you look at some angiographies or MR angiographies, you'll see that these vessels just kind of, they hang out. They literally they're not functional. They're dysfunctional until we're asked to do something with them. Now, here's your middle cerebral here. Here's your anterior cerebral. And this right here, let me move this over a little bit. Right here, this tiny little bridge, that is your anterior communicating artery. So we have one anterior communicating artery, or ACOM. Some people call it ACOA, but most people call it ACOM for anterior communicating. And we have two tiny little posterior communicating arteries here and one here. And these posterior communicating arteries, I'm sorry about this, I don't know why it's slipping here. These posterior communicating arteries will interconnect with the PCA, and you're going to see that as we go along. Okay, so I'm moving too quick here. The supraclinoid segment is right here. So this is the very last segment of the internal. So the internal comes up right here, breaks through, and loops behind the eye, and it now trifurcates, if you think about that. It first forms your PCOM, then your NCA, and then your ACA. So it's a trifurcator. So the internal comes up, loops behind the eye, supplies blood to the eyeball, but then breaks apart and becomes the little PCOM, the NCA, and the anterior cerebral artery, the ACA. And Bob is pointing, if you see that, Bob's pointing to the ACOM there. All right, or anterior communicating. All right, so this is just giving you an overview. So here's the terminal ICA here. This is where the internal is terminating and saying, I'm done being internal. Here's your little ophthalmic artery. Here's your middle cerebral artery. Here's your anterior cerebral artery. Here's your PCOM, posterior communicating artery. Here is your anterior communicating artery here. Remember, your PCOM attaches to your PCA here. Here's both vertebrals forming your big basilar. At the top of the basilar, we have the posterior cerebral artery. The posterior cerebral arteries attach to the internal carotid artery via the PCOM. The anterior cerebral artery will cross over using the bridge, the ACOM, to feed and protect the other side of the brain. Okay, this is your anterior communicating artery bridge there. And we're going to talk about that as we go on. Now let's go to the posterior circulation real quick and we'll talk about that. So remember, subclavian comes off of the, sorry about that. The subclavian comes right off the arch on the left side of the body. On the right side of the body, it comes off of the innominate or brachiocephalic. The very first branch of the subclavian is the vertebral artery here and the vertebral artery here. Remember, the subclavian supplies blood to the arm, and the vertebral artery supplies blood to the basilar, which supplies blood to the brainstem, which is our dizzy-woozy center of the brain. So if you have subclavian steel and the person's scrubbing their arm or playing tennis, they're scrubbing their wall or they're playing tennis, they're having dizziness, that's because blood is being stolen from the vertebral artery to supply blood to the brainstem. So hence we have the brainstem symptoms with subclavian artery stenosis. Okay, so look at the vertebral artery here. When we're doing carotids, and I'm sure most of you do carotids, when we're doing carotids, we're looking at the vertebral going through the transverse processes here, okay? What we're talking about with transcranial is when it's looped around C1, C2 here. So we're looking at intracranial vertebral artery beyond the foramen magnum. Remember, the vertebral arteries form the big basilar artery here, and again, supplies blood to the brainstem. And I'm going to show you some distribution in the brain. So this is a pretty easy graphic. Both verts here and here supply blood to the big basilar artery, which at the top of the basilar we have our posterior cerebral artery. When they talk about the TOB, that's the top of the basilar. They're talking about right here. This is where the basilar says, I'm done being a basilar. I'm now going to bifurcate and become PCA and PCA. Now, when you're doing the posterior circulation, a lot of times, especially people that do the non-imaging, a lot of times I'll get calls and people will say, well, you said flows are going away from the probe back here. But when I'm doing my basilar, and I know it's my basilar because I'm deep, I know it's not a vertebral, I'm getting flow coming towards me instead of away. So I'm getting both flow towards and away. What is that? And the answer is, it's these tiny little pontine arteries that are coming off of the basilar. The basilar looks like a millipede, if you think about it. But there are many, many vessels coming off of the basilar artery here, okay? So that's what they are, and you just want to ignore them. You know, you can't make them go away. When we're doing vertebrovascular evaluation, we want to look at everything going away from the probe. So those verts will be going away from the probe as well as the basilar artery. Okay, so let's move on. Again, the top of the basilar, or the TOB, top of the basilar, is those posterior cerebral arteries. And this little tiny string sign right there, that's your PCOM, okay? That's your posterior communicating artery. Okay, so an overview again. Let's just discuss it real quick. Think about this water here being our neck and the vessels coming up. The internal is stopping right here. It's terminating. It's sending a branch to the ophthalmic artery. It's forming an ophthalmic. It's forming a PCOM. It's forming the MCA and the anterior cerebral artery. So middle cerebral, anterior cerebral. Here's our bridge, the ACOM, connecting right and left anterior cerebral arteries. In the back of the neck, here's vert 1, vert 2, forming the big basilar artery. At the top of the basilar, we have 1 PCA, 2 PCAs, okay? And this is our circle of Willis here, this whole little guy here. That's our circle, or the cow. Some people call it cow. Okay, so during this presentation, and I just wanted to just mention this before we go on, because we are going to be using the simulator, and Dr. AASLID is the inventor of Transcranial Doppler. He's a Norwegian physicist that introduced TCD to our country in '84, developed transcranial in '86. So Dr. AASLID developed a hemodynamic simulator that everybody who teaches nowadays pretty much uses. And if you would like to get it, and I'm not here promoting anything or selling anything, but if you would like to get the simulator, you can go into www.hemodynamics.com, or fortunately for us in this country, Natus Neurology they do distribute them, they do sell them. But if you go on the website, I think you can download now. He used to send you CDs, but I think you can download them now right onto your computer. Okay, so let's talk about intracranial anatomy. We talked about the vessels leading to it, and we're going to talk a little bit about the circle of Willis. The circle of Willis was identified by Thomas Willis, who found this intercommunicating set of arteries in the subarachnoid space. Now, this is kind of important because we have a lot of different types of blood that happens in the brain. So you have intraventricular hemorrhage, intracerebral hemorrhage, epidural hemorrhaging. None of those cause vasospasm. Only subarachnoid blood will cause vasospasm.
Hold on. Yeah, hold on, everyone. It looks like we lost Sonali's audio. We'll get her back on the line and continue the presentation in just a minute.
Okay, I don't know if you can hear me. I think we got kind of disconnected. Okay, so this is Thomas Willis. He is a neurologist. This is what he looked like, nerdy neurologist there. He published the Circle of Willis in 1664. So this has been around for quite some time. And again, it's located in the subarachnoid hemorrhage. Subarachnoid space, I'm sorry, not subarachnoid hemorrhage. Okay, again, Circle of Willis, the blood supply comes from the internal carotid artery and the basilar artery. Communicates via one ACOM and two PCOMs, or posterior communicating arteries. So one anterior communicating, two posterior communicating. All right, so here's the Circle of Willis here. This is our cow. You can see here's our middle, our anterior cerebral, our ACOM. This is the second segment of the anterior cerebral. Here's your communicating artery here. This is the PCOM. This is the PCA, and this is the top of the basilar. So there's our circle. So middle, anterior, ACOM, anterior, PCOM, PCA, top of the basilar, and so on. Okay, so that is the Circle of Willis. All right, the purpose of the circle is to shunt blood from right to left or posterior to anterior. So we can get blood from the back of the brain to the front of the brain, or from left to right, following an obstruction proximal to where we are in the brain. Now this is important. It only happens during carotid occlusions, and we're going to talk about that in a few minutes. But if you look at this right here, 18 to 20% of us have a normal Circle of Willis. So that's not very many people. A lot of people do not have normal Circle of Willises. Up to 50% have very small PCOMs. This is people say, well, how can TCD be so sensitive if only 20% of us have a normal circle? Well, the answer to that is because most of the problems happen in our bridges. So it happens in the ACOM or the PCOM, which we don't see anyway when we're doing TCD. Again, even with imaging, you do not see it. All right, so I promised you an MRA showing you how small these vessels were. So you can see we're looking down on like a bird's eye view of the brain. So here's our circle right here. This is our middle. Here's our anterior. Look, you can't even see the ACOM, but it's right there if you use your imagination. Right here is the PCOM on one side, but look at the other side. There's no PCOM there. It's gone. Now, was this patient, did this happen because they were in that automobile accident a couple of years ago? You know, were they hit in the head? No, this patient was born with this. They would have probably never known they didn't have a PCOM. They just happened to have a history of migraines, and we did an MR angiography on her. Okay, so you're born with these. This isn't something that just occurs just because of trauma or what have you. Okay, so ACOM and PCOM, again, are not routinely visualized. We do not see them. Even if they are, let's say they are collaterals, let's say they're open, the bridges are open, we are only going to see weird flows and hear very, very turbulent. You're going to hear turbulence. Even with imaging, you cannot see these bridges when they're open. Now, as far as territories, I want to show you the middle cerebral artery supplies blood to a huge portion of the brain. The anterior cerebral artery is mainly the frontal lobe. The posterior cerebral artery is mainly posterior. Here is your cerebellum and your brainstem. this is supplied by the vertebral-basilar system, okay? All right, so with that, that gives you a little overview of our anatomy and the anterior communicating artery and the posterior communicating arteries, and we're going to talk about the actual collateral flow patterns now. Okay, so when we have a patent communicator, meaning when our bridge is open, you see it only occurs when there is a hemodynamic situation proximal to where we are. So we're up in the brain. Something has to be occluded, proximal meaning close to our heart. So it's got to be in the carotid artery. It could even be above the mandible. It could be going through that foramen lacerum. You could have maybe a lesion like above where your, below where your cheekbone is. The important thing is that it's proximal to the brain. It's proximal to where we are. It is not present in other pathologies. So we do not see, our communicating bridges do not open up if you have, say, an arteriovenous malformation, if you have a blockage in the brain. Let's say we have an MCA stenosis, severe stenosis in the middle. Let's say we have an aneurysm and they have vasospasm. These bridges do not open up in these scenarios. They're only functional whenever we have a carotid occlusion or near occlusion. It does not have to be occluded. Now remember, when you have patent communicators, if you're doing non-imaging, you are not going to see the flow turbulence and when you're doing imaging, you see the eddy currents, you see instead of it being blue and red, you'll see yellows and whites, where the anterior cerebral artery is and where the PCA is, where if you're doing non-imaging, you're not going to see that. You're going to have flow turbulence. Many times you're going to hear murmurs. Now here's one thing you're going to see. You're going to have opposite flow direction patterns on the ipsilateral side of the occlusion. So let's say I have a right carotid occlusion. Let's say my anterior communicating artery is open. My anterior cerebral artery will not be going the normal direction. And I'm going to demonstrate this for you with the simulator. So that's one thing you're going to see. Two things. You're going to hear the turbulence, the flow, the murmur, and you're going to have flow patterns that are reversed. They're not normal. Okay, so let's talk about posterior circulation. What will we see there? So here we have the crossover here anteriorly. Here's the PCA. You can see we've got posterior collateral. So the PCOM here is open and sending blood also to the terminus, which will feed the middle. So this person's lucky. They have both bridges open, here and here, and they could occlude this vessel and not have a stroke. And this is why, how many times have you done carotids on people and, say they're pre-open heart surgery. You do a carotid artery for a pre-op evaluation and, you find a carotid occlusion and you're like, did you ever have stroke? And they say, no, I was dizzy that day, but that's about it. That's because these patients have so much protection because both bridges had to be open, or they had a whole lot of collateral through the anterior and posterior. Now this person, they have the ACOM there, but because their A1 segment's hypoplastic, the flows are just going out the second segment here. This patient has a PCOM that's very, very hypoplastic. This happens in about 30% of people, so it's not uncommon. All right, so patent posterior communicating artery, you're again going to see higher flow velocities in the ipsilateral, meaning on the side of the carotid occlusion, you're going to, or near occlusion, I have to keep remembering to say that. it's going to be higher on the side of the hemodynamic lesion. You're also going to have higher velocities in the basilar artery. Not high to where it's going to be like a stenosis high, but it's going to be, normal basilars are in their 30s. It's going to be maybe 60. And it's going to be throughout the whole segment. And you're going to be a Sherlock Holmes. I mean, let's face it, when you're doing any study, you want to look at the whole ball of wax. You want to look at, we're looking at the body as a system. So what do the carotids look like? If the carotids are clean and I have high flows in the basilar, you're certainly not going to say, well, that's collateral, because it's not. Their carotids are clean. They're open. So you have to remember, if you have high flows or flow reversals in these other vessels, you've got to think about, you've got to look at the carotid artery. Think about, well, what does it look like downstairs? I know what the upstairs looks like, but how healthy do I look downstairs? Okay, so now we're going to use a simulator, and we're going to first talk about posterior collateral. And I'm going to go up into share, and I'm going to share my screen here so that you can see, this is my new little grandbaby. You can see her for just a second, and then we're going to see this. Okay, so let's get our waveform up here. Okay, so let's go down here, and again, this is the hemodynamic simulator. It's the AASLID hemodynamic simulator. So let's right-click into our common and give us a 90. Before we do that, let's do this. Let's look at normal flow. So let's increase our depth. Okay, so we're in the middle cerebral artery right now. So as I go deeper, there's our anterior cerebral, right? Going away from the probe. And then if I go back, that's my posterior cerebral, right? Here's my wimpy ophthalmic. Let's do our ophthalmic. Wimpy ophthalmic over here. Vertebral back here, away from the probe, away from the probe. Here's the basilar, again, away from the probe. So let's go up here again to our middle. And let's go down here and let's right-click and give this dude a 90% stenosis. So you see my flows went from 60 down into the 40s. Let's bring up our blood clip study. So this is showing us that even though we have a lesion in our neck down here, my flows are pretty good. 40 on one side, 43, 44. They're pretty much the same. So let's see what our PCA looks like here. Oh, wow. The PCA is 114 on this side. What is the posterior normal? It's about, what, 40? So it's like almost 3 times its normal. Let's see what the posterior looks like on the other side. So it's normal. So when you have a carotid occlusion or near occlusion, and you have high flows in my PCA, you're not going to think there's a stenosis in the posterior cerebral artery. You are going to think collateral flow. Okay, so let's go back. I'm going to stop sharing. Okay, we're going to go back to our PowerPoint here. I don't know why this stays up there. I'm just going to leave it there. All right, so now let's talk about anterior circulation. All right, so again, if you have the bridge open here, what are your flows going to look like? You've got flows from the one side of the brain crossing over. Think of it as the troops going over and protecting. They're helping out protecting the other side of the brain, sending flows back into the middle. okay? Because we've got a blockage down here. So this is crossover collateral, if you think about it like that. Okay, so what are we going to see? We're going to see higher velocities in the contralateral anterior cerebral. That means the normal side. So over here, because this anterior is doing twice the work, they're probably going to be high. They're probably going to be, instead of being 50, they're probably going to be 100. Flows here are going to be, instead of going away from the probe, they're going to be coming towards our probe. Okay, so you've got flows towards here, and then as you go deeper, you're looking for that MCA-ACA bifurcation, and you've got flows coming towards you, and you're like, what in the world is going on here? This isn't making sense to me. Okay, so you're going to have higher velocities in the normal side, flow reversal in the abnormal or occluded side. And we're going to use the simulator again. I'm going to go up here to share my screen. And I'm sorry we have to do this, but it's the only way we can do it. Okay. So let's go up here. And let's make this PCOM. Okay, so let's increase our depth. We know that's 50, that's our middle. Increase our depth. So at 60, it's like, oh man, I should be seeing an anterior cerebral here pretty soon. Where is my ACS? So as I go deeper, it's like, oh, what is this I'm seeing? This is what we call mountain on mountain. So this is your middle right here. This is your anterior cerebral artery coming towards the probe as the flows are going across the communicating artery here. This is not your anterior cerebral. If you were to have the measurement on that, you're going to get flows here in the 20s. This is not the ACA. This is a branch that's dilated up. So this is your middle, and this is your anterior coming towards the probe. Remember, you only see this, folks, when you have got a carotid occlusion or near occlusion. So let's go back here to the middle, and let's take out our bridges. Let's make them missing. Now, again, this is only going to happen in probably less than 5% of people. So what do you think is going to happen? Let's turn our scale down. So let's make this ACOM here missing. So you see we've got a terrible hypoperfused state here, and we're being warned you're having a stroke. Danger, Will Robinson, you're having a stroke. Okay, so this is why people have stroke that don't have normal bridges. Okay, the ideal scenario is to have these bridges open. Okay, so let's stop sharing the screen. We're going to go back to our PowerPoint presentation now, and we're going to continue. Okay, so what I just showed you, when you have a patent anterior communicating artery, you're going to have what we call mountains on mountains. So you're going to have the middle cerebral artery being close to your baseline, and in the background, you're going to have that reverse ACA coming towards you. You are only going to see this in the presence of a hemodynamic lesion proximal to where we are in the brain. Now, here is the peculiar thing. When the doctor goes in and they either put a stent in or they go in and endarterectomize this vessel, the anterior cerebral artery will completely reverse immediately. It completely returns to normal, okay? I didn't think that would happen. I thought it would take a couple days or something. No, it returns to normal immediately. which is kind of interesting to me. The body amazes me. All right, so we're going to finalize this talking about the face-to-eye collateral I talked about earlier. Okay, so this is, again, the external carotid artery. It's just an angiogenesis to the ophthalmic artery, so kind of like they interconnect vessels. It is usually the last to form. So you can see here, this is a nice netter slide. I love it. So here's your external carotid artery here, and you can see how even up over the convexity, you've got branches attaching to the ophthalmic artery and sending blood back into the brain, back into the middle. So, of course, what are you going to see in this ophthalmic artery? You're going to have a flow reversal because blood's not going to the eyeball. Sure, the eyeball's getting blood, but it's through these small branches. The ophthalmic artery is literally feeding the brain, I have seen more than a handful of physicians that have endarterectomized an external carotid artery here. You know, normally they don't touch them. If there's disease in that external, the doctors are like, so what? Who cares? You know, you're going to lose your, feeling in your cheek. They don't touch them. They'll clean out the internal but not the external. But here's the caveat. If you've got a blocked internal and that external has disease in it, and they know darn well that's the only way that brain is being protected, they will clean out the external carotid artery. Again, it doesn't happen often, but it does happen. Okay, so what are we going to see? We're going to have increased flow velocity in the ipsilateral external carotid artery. You're going to have flow reversal in the ipsilateral ophthalmic artery. So not only is your ECA going to be higher, but you're going to have flow reversal in your ophthalmic. And guess what that ophthalmic artery is going to look like? It's going to look like an internal. Just like when you do carotids and the carotids occluded, you see the external taking on the shape of the internal. The same thing happens in the brain. The ophthalmic artery, instead of looking like a baby external, will now look like an internal or a middle cerebral artery. It'll look like that. It'll look like a siphon, and it's going the wrong direction. Okay, it's not coming towards the probe. The ophthalmic artery loses that high resistance. On the other side, you're going to have a normal contralateral ophthalmic artery, so it looks normal. All right, so let's share our screen again, and we're going to look at the ophthalmic. Okay, so let's make the A-plane here missing. Okay, so let's look at the normal side. There's ophthalmic there. Let's look at the other side. You see the difference here? It's reversed, and it looks like a siphon. And it's saying, turn that power down. Yeah. Okay, so normal ophthalmic, collateral ophthalmic. Now, you don't necessarily have to see this every time you have carotid disease. This pathway, face-to-eye pathway, happens at the very end. Like when all else, it's like the last resort. Let's think about it as that. It's the last resort. When all else fails, we're going to do face-to-eye. Okay, so let's stop sharing. We're going to go back to our PowerPoint here. And we're almost done. In conclusion, transcranial Doppler is very sensitive in identifying collateral compensation. And it's important, when people say, well, you've got a carotid duplex that's abnormal, it's good to complement your carotid duplex exam with transcranial. Number one, you can identify emboli from a ratty-looking plaque in the neck, which we'll talk about another time. But more importantly, you can identify the collateral flow patterns. If I've got a lesion in my neck, what's my brain doing? What's my risk for stroke? It assists the physician in identifying patients at higher risk of stroke. It's telling us, well, they don't have any bridges open. It's bad. It's danger will. They are not protected. They're going to need to have an endarterectomy. Okay, so thank you much for joining. If you would like any on-site transcranial Doppler training, you can go to my website or call my number there on the screen, and I'd be happy to come to your institution or your doctor's office and give you some training for your group. Okay, thank you so much again for coming, and I'm going to pass this back over to Katie for some questions.
Well, Donna Lee, thank you so much for your wonderful presentation. We enjoyed it as usual. All right, here's our first question. Is there always an ophthalmic artery collateral to the external carotid artery?
You know, good question. It doesn't always happen. Like I say, that's the very last to form, Katie, just because it's almost like an angiogenesis kind of thing, where the bridges are just going to get big. They're already there, and as the vessels, when the vessels in the neck are slowly closing up, the vessels in the brain are slowly dilating up. Now, I will tell you that if, let's say someone's got a carotid dissection, they were kicked in the neck, the collaterals don't have a chance to form. So a lot of times that's why these patients, you know, will do an angio and they're like, wow, they have communicators, why didn't they work? Well, that's because they take time to form. Now, as the vessel in the neck, the carotid slowly closing up and the brain sensing, I'm not getting any protection, that's when your face-to-eye collateral will kick in. It does not happen every time. It doesn't happen every time. It depends on your bridges.
Thank you for clarifying that. By the way, the question was wrong, so I read it wrong. The question should have been, is there always an ophthalmic artery collateral to the internal carotid artery? And I think I said external, so I apologize for that. But you answered it correctly, Donnelly. Okay, here's another question. Are the collateral pathways present in an intracranial occlusion, such as an M1 or M2 occlusion?
You know, they aren't, Katie. And, you know, again, that's what makes this whole collateral phenomenon so simple for us. It only happens when there is a lesion, hemodynamic lesion proximal to the brain. So anything that's going on inside the brain, the collaterals don't do anything. The bridges just still hang out. So like carotid, internal, even siphon would cause it, but not like an MCA stenosis or occlusion. Correct. Okay. No M1 occlusion, no M2 occlusion, moya, nothing like that. Thank you. Okay, here's the next one. Are the abnormal flow patterns reversed following a carotid stent placement, or does that only occur with a carotid endarterectomy? No, I've seen them occur with both, and that kind of surprised me. I didn't think I'd see it. In fact, it happens right away. I didn't think it would happen as quickly in the stents, but it does. Once they open that up, the ACA completely goes back to normal, and your PCA, if it's real high, if you've got that PCOM collateral, they calm back down again. They return back to their normal flow pattern. Very interesting. Okay, we have one more question left. If there are any other questions, please send them in now. The last question, Donna Lee, and I think you actually did address this some, but the question is, how do you differentiate high flows in the PCA when is it a collateral flow or is it actually a PCA stenosis? Well, that's a good question. Okay, so first and foremost, and you can ask any physician this, PCA stenosis are very, very rare. They happen in less than 5%, and I think the percentage is actually 3% of intracranial pathology is from PCA stenosis. That's number one. Number two, you have to have that ipsilateral carotid hemodynamic lesion. That's going to be the determining factor. When I was saying you've got to be kind of a Sherlock Holmes, you're finding abnormal flows upstairs, well, look through your paperwork and see what their carotids look like, see what their CTAs look like, and you're going to get your answer. So if you've got high flows in the PCA and you have carotid disease, you can pretty much bet that that it's a collateral PCA. If you have high flows in the PCA and the CT shows hemorrhage, subarachnoid hemorrhage, you might have some vasospasm starting there. So you kind of have to look at everybody, like, get the whole picture. And we all know that.
Donna Lee, once again, I do want to thank you so much for giving us this valuable information. Thank you so much.
Thank
Bye-bye.
you. Bye-bye.